Belgium, being guest professor for different TCM college. So now we would like to give the chance for Professor Dr. Jiang to introduce our next speaker, Dr. Xu.
I just recommend about Dr. Xu. Dr. Xu is initially graduated from Nanjing University acupuncture profession. Then he has his PhD in the Leiden University in the Netherlands. And now Dr. Xu is a senior scientist in the Roche Innovation Center in the Zurich, and is leading several drug discovery program in the cancer immunotherapies. So I think now the Dr. Xu should be give us talking about exactly the difference in the immunologic position for the cancer problem.
Great. Thank you very much. So I hope I'm not gonna disappoint you because I'm not gonna talk about Chinese medicine. So I will look into the cancer from a different angle. Try to give you a brief snapshot on the modern cancer immunotherapy to look into how the cancer immunotherapy is going to be involved. During this whole drug development is very important because there's several criteria, particularly the safety margin of the drug candidate before we move into the clinical trials is very important to consider. As long as there's any safety concerns, then this drug usually will not be developed further into the clinical trials. So I mentioned a few companies right now. These are the top, let's say, top five pharmaceutical companies in the world. So in Switzerland, there's two big companies. One's called Roche, which I'm working with, and Novartis is another company, is our major competitors. And then there's three big companies in the US called BMS, Merck, and Pfizer. And all these big companies, they are making a lot of drugs. So here, I just show you a graph and to show how many drugs have been approved in the last 5 years. And you can see basically. So I also mentioned here, and the FDA, the American Food Drug Development Administration, that is an agent. They approved the new drugs, and they made a new designation called the BTD, so breakthrough designation, which means if you have a drug which shows very promising positive results in a small clinical trial, that basically they say if even in the phase 1 trials, if you see outstanding results, and FDA like to really bring these molecules into the market as soon as possible, to bring into the patient as soon as possible. So, and they give this designation to this kind of new drugs. And in the past, we received most of the breakthrough designation drugs from our company. But also, I think all this, the outcome is quite correlated to the investment we put. And this is our annual investment in drug development. So it's in billions. So $8.5 billion we spend per year into the drug development. So now back to the science. I like to talk about the cancer immunotherapy, but importantly, I think it's very interesting to read the history, because already more than 100 years ago, the people already discovered that the immune system could be used to fight against cancer. So this doctor, William Coley, he's a surgeon. So occasionally, he discovered that some patients, they somehow experience a spontaneous tumor regression. And then that was correlated to those patients who already had an acute bacterial infection. So he thought, okay, if you have a bacterial infection, which means the immune system being activated, then in this way, the activated immune system can be used to fight against cancer. So then he treated several patients and just gave them some bacterial infection. So he makes the kind of nowadays we call it toxin. And so that became one of the patients. And this, what he reported is one patient had a complete recovery and lived for another 20 years after being injected with a live bacteria into the malignant tumor. So that's the first evidence that immunotherapy is powerful. It can be used as a cure for cancer. Of course, because of that early time and because of the advent of X-ray and the radio treatment and chemotherapy, so his work has been basically shutting down by the whole community and being forgotten by the people. And people think, okay, this immunotherapy just probably this is just happening in very minor cases, and not like the X-ray, not like the particular chemotherapy and radiotherapy lately has been proven and a standard of care for cancer treatment. So it took the community almost as long as for 100 years. Okay, sorry, okay. Yeah, probably it's easy. Okay. Yeah. So it took us probably as long as more than 100 years to really prove that immunotherapy is really a powerful therapy. So in 2003, the most influential magazine for science, they rated cancer immunotherapy as the breakthrough of the year in science. So because nowadays we realize the cancer immunotherapy is so powerful because it attacks the cancer systemically. And then it's so specific because it really trains your own immune system to recognize and target only the cancer cells, So it's totally different from the chemotherapy, which recognizes overall all the cell type. And then, more importantly, the cancer immunotherapy also induces a memory. So which means when you have new cells, new growing cancer cells come into the body, and it can be recognized by the immune system, which had developed a memory, particularly the T cells. So when we look into cancer, we also look into the cancer differently. This is a biopsy we take from a cancer patient. So we just do an immunohistochemistry, look into what are those cells, what are they in the cancer. So we can clearly identify those different components of the cancer immune system. For example, in this case, we can clearly see, okay, there's a blood vessel here, but there's some immune cells being infiltrated into the cancer. And then we also see where the cancer cells are they. So even in some cases, we see a tumor, a nest, which form a big clumps of the cancer. So based on this, we can really see every patient will have different immune composition, which means they might respond to the therapy differently because of the immune composition, because of how the cancer cells being formed, being surrounded by different immune system. So based on all this information, we can develop a specific target. This is a new trend of cancer drug development. So, but then thinking about immunology, there's actually a continuous cancer immunity cycle going on in the body, which means talking about a tumor cell, a tumor mass here, and then often there's always some cells will die, for example, by spontaneous apoptosis, and then there's professional antigen-presenting cells are able to recognize these dead cancer cells and then process the cells, eating them up and chop into the small peptide or antigens. And then they can present this antigen to the T cells to activate even when the T cells still in the naive stages. They can make these T cells to develop and to mature, to proliferate, to become effector T cells, which they then migrate into the lymphoid organ, then eventually migrate to the tumor site to exert their killing function. That's when the system is normal. Here we're talking about healthy body, a healthy people, or when you've got some cancer cells, but the immune system are able to check in and kick in and to control the tumor growth. But in most of the cancer patients, this doesn't happen. So what we do is we can attack every stage of these cancer circles. For example, we can increase the antigen presentation by certain activate particular these cells. We can also induce something to trigger the migration of the T cells to the tumor site. And then there's other things we can block, say, because in the tumor microenvironment, there's also very many bad cells that are sitting there. We can find a way to remove that and also to modulate the whole tumor microenvironment. So now, I mentioned this chemotherapy, which is a history. What happens is chemotherapy never cured a cancer. So this is looking at the overall survival curve. So in the end, all the patients will die. Why? Because chemotherapy has no specificity, which means, for example, I give you an example. During a war event and on a field battle, for example, so both your own soldiers and the enemies are fighting together, and then you throw a bomb. What the bomb do is they're gonna kill the enemies, but also it's gonna kill your own soldiers. That's why chemotherapy never really cured a cancer patient. Eventually, could even potentially promote the death of the cancer. Of course, it prolongs the life of the patient. That's why chemotherapy has been a standard of care in the past many years. But lately, because of development of the modern science, and we realize in many of the cancer patients there's mutation, there's specific mutation to a particular genes, to a particular proteins, and then that leads to the really a proliferation of the cancer cells to make the cancer cells to survive better. Then that made a targeted therapy came out of life, where we can develop a drug which specifically to block that receptor, to block that mutation, to block the proliferation of the cancer cells. Of course, it does much better than the chemotherapy because we have a specific target here. But the problem is, this targeted medicine still does not really cure the cancer. Eventually, the patients still die. And you can save some amount of life. That's all you can do. And also, in reality, a lot of patients, they got resistant just years, 2 years after the therapy. So which means you have a targeted medicine which targets this particular mutation, but then the cancer cells are so smart, they can develop another strategy to avoid that attack, which means they can develop a new kind of mutation to avoid the immune system to be checked. So nowadays, we develop immunotherapy. So at least things starting from 2013, we see several drugs in the market already being proved in the clinic. Some of the medicine could lead to a dramatic survival advantage to this patient. This is shown in the blue lines here. So which means you do not cure all the patient, but still in a subset of the patient, they live longer, even live indefinitely, even live without a tumor in the end. So that's also the current status, and also the future of the cancer therapy, at least from the Western medicine field. So I mentioned this chemo and radiotherapy. What it does essentially is anti-proliferative, because that means it is trying to block the proliferation, to block the survival of the cancer cells. Basically, it does just to try to kill the cancer cells. Again, as mentioned, there's no specificity of this chemo or radiotherapy. So the immunotherapy, there's many different types of immunotherapy. And I'm going to focus on one of the major things about the immunomodulator or antibody-targeted depletion. So I give you a few samples how we develop a drug to deplete certain cells using antibody, recognize the antigen on that particular cells. And there's also actively work going on in the world and try to make a vaccine against cancer, but that's being proven quite challenging, quite difficult. And another quite interesting therapy is called adoptive T-cell therapy. So which means you take the patient blood population and you extract and then take out in ex vivo, and then you can engineer those cells And after, to make those cells to have the effector function, to make those cells to have the specific recognition to the particular tumor cells. And then you can fuse back to the same patient to let them to attack your cancer cells. So I mentioned, because of it starts from 2013, and people try to really realize the power and the importance of the immune system contributed to this, contribute to the treatment of the cancer. So now looking at the human bodies, I mentioned there's a different therapy in the past. I gave you a few samples of the targeted medicine. Actually, this is our own company's drug. For example, so I mentioned that the oncogenes. For oncogene means which the genes which promote the oncogenesis of the cancer development. And then you can use certain drugs to just block these oncogenes. For example, if there's a kinase, you can use an inhibitor to block the MEK kinase. And if you have the HER2 expression in the breast cancer, you can use the agent to block the HER2. And then you can also block the angiogenesis, which Dr. Zhao mentioned this morning. Angiogenesis is important because for the tumor to grow, you need the blood vessels. So then what this drug is doing is to prevent the blood formation, blood vessel formation, and then to basically to remove the nutrition to prevent the tumor to grow. So, but I will focus more on the immunotherapy side. And essentially, there's many different types. You can have some drugs to activate certain molecules, and you can have something to modulate the immune system, to modulate the whole tumor microenvironment. You can also develop a specific target or antibodies. Here we call bispecific. Bispecific means you have two recognition moiety. One is you have antibody, we have two recognition arms. So one is binding, for example, to CEA. This is a tumor antigen. And then you can, on the other arm, you can bring another CD3 antigen. CD3 is expressed by T cells, which means you can bring your T cells to the proximity of the tumor cells, and then to activate the T cells locally inside of a tumor, to let the activate T cells to kill the tumor cells. So for that, for a hematological tumor, we can use CD20 for them on the B-cell lymphomas. So, more detailed, we're talking about antibodies. Modern technology has evolved so much, and you can do a lot of these things we call engineering to modify the antibody function. So antibody is composed of Fab and then FC portion, and then in this case, for example, if the antibody will recognize the tumor antigen, and then the antibody will bind, then you can fuse your antibody with a kind of toxin. So, which means when the antibody binds to the tumor cells, the toxin will be released and to kill the cancer cells directly. That could induce a specific cancer cell killing. And then there's another type of cancer antibodies I talked about. For example, for B-cell lymphomas, the B cells express CD20 as antigen. So we have the antibody recognizes CD20. Then we have CD3, which recognizes T cells. So which means one antibody binds to two cells. One is on the tumor cells, one on the T cells. And then T cells are going to start the killing activity. I'll give you a few samples. And then also mention the rituximab, which is one of the main blockbusters invented by Roche. And just looking at this figure, again looking at the survival curve of the patient. So this, in the older time, here I'm talking about one of the aggressive non-Hodgkin's lymphoma called diffuse large B-cell lymphoma. And since 1980, when the chemotherapy was developed, actually there's a combination of 4 drugs called CHOP. It's a standard of care for any patient with non-Hodgkin lymphoma at the time. And actually, it does not that really bad because it really kills about 50% of the patient. But then because of the invention of rituximab, so we had this drug lately become our standard of care. Since then till now, actually, still nowadays, still the standard of care. What it does is just use the rituximab plus CHOP, the chemotherapy, and then it improved the cure of the patient. So basically from 50% to close to 70%. That's a 20% increase of the patient life. So that's a significant, very significant improvement. So just to brief mention, I mentioned to you, so the antibody CD20, rituximab, is we have the antibody recognizing antigen on the B cells, on the B lymphoma cells. And then that antibody, because of the FC function, could activate the complement, could activate the ADCC, that leads to the elimination of the cancer cells. And then just 2 years ago, in our Zurich site, we made another drug into the market. That's improved the second generation of the rituximab. It's called Gazyva. And this antibody, even performing much better. These are clinical trials, which is, I think it's only phase 2A trials, small trials, that already lead to a breakthrough designation approval by the FDA of this drug. So that's in the clinical trial for patients with chronic lymphocytic lymphomas, CLL. And as you can see the curve, so again looking at the survival curve, our new drugs improved very much of the life of the, as compared to those patients who were treated previously with rituximab. So here we're talking about median survival from 50 months to 26 months, by 11 months difference. So also the risk of the risk has been reduced by 58%. That leads to the approval of these drugs, yes? Okay. So now I mentioned to you, okay. So this is just one type of strategy. And then if you think about the T cells, say, let's try to activate T cells in a tumor. There's many ways. Because T cells express many receptors. And this receptor could be activating receptors, and it could be inhibiting receptors. So what you can do is, okay, you can make some antibodies to activate one of these, or many of these receptors, to make the T cells more active. And you can also make an antibody to block the inhibitory receptor, which, if the T cells express one of these, the T cells will become non-functional. So you can make an antibody, for example, to block the PD-1. This is also the antibody Dr. Zhou mentioned this morning. So it's the most powerful drug currently in the market, and which makes a lot of money, also saves a lot of the patient's life. I'll also make some detailed explanation on this drug in the later slides. So I'll give you another example. When we look at the immune system, we can actually image how the T cells is exerting the killing activity. Here we are talking about the activated T cells, which is in red. And then we have blue cells, which in the cancer cells. So when the T cells could specifically recognize the tumor cells, what it does is really provide a powerful weapon to kill these tumor cells. It's really chase the tumor cells everywhere it goes. And then in the end, it's going to eat up and chop up the tumor cells in the very end. So I mentioned the PD-1. This is the most interesting drug currently in the market. It was initially approved in 2013. There's 2 drugs that have been approved. And it saved many of the patients, particularly in metastatic melanoma, but also in other type of cancers. So the mechanism how this drug working is very interesting, because lately people realize that tumor cells actually they express a particular ligand called PD-L1. Once the ligand is expressed, and it goes signal to the T cells, which express the PD-1. So I mentioned the PD-1 is one of the inhibitory receptor. So if the ligand, there's a lot of ligand in the immune tumor microenvironment, when they bind to the T cells, it completely inhibits the T cells to be functional. So which means T cell will be sitting there if there's any, but they cannot kill any tumor cells because of the signaling through the PD-L1. So then people realize this could be a powerful strategy to let's say, release the kind of break signal on the T cells by using antibody could block either on the ligand or using antibody blocks the receptor. But also to realize that's also only happened later, and investigators realizing actually not all the patients are the same. So here we're just looking at the tumor staining for this PD-L1, looking at the brown staining. These are patients who have a massive PD-L1 on their surface of the tumor cells. But then there's some patient had a little or less expression of the PD-L1. And there's even some patient without any of the signals. And now it's been proved that if we have a patient who comes into the clinic, and then usually we took a biopsy, if we see this kind of stainings, and then this drug will not be provided, because in most cases, and this drug is not going to work in this patient when there's no PD-L1 expressed by the tumor cells. And also often in this case, there's no T cells around. This is a perfect example to show how the cancer drug development being made in the whole process. I show you this, actually, when talking about science, it's really, this molecule, the receptor, it's called PD-1, has been discovered in 1992 by a Japanese lab. And then, just few years later, and people discovered a ligand which could bind to the receptor. So you see how process evolved. And then the same lab who discovered the receptor found out that this drug, this ligand, actually is really the right ligand because it's binding specifically by the receptor of the PD-1. And then still took another year, the same lab come here, as Chinese lab at that time at the Mayo Clinic in the US. And then they discovered, actually, this, if you block the PD-1 or PD-L1, this could enhance the benefit of having, at least in the tumor-bearing mice, if you block the signal, the tumor will get rid of will be eradicated in those mice. So this provided first of proof of concept. Then the industry people start realizing this could be a very powerful pathways to attack. Then that leads to a long process, development process, in the end in 2014, and these two drugs being approved. And a new drug, which target ligand, was approved just in May this year by my company. So I summarize the clinical trials. So as I said, this cancer immunotherapy are very powerful, but they cannot kill all the patients. Here I just summarized you the objective response rate. What does it mean? Response rate includes the complete response. What does it mean? The complete response means the cure of the tumor completely disappeared after several cycles of the treatment. And then, but it also includes the partial response, which means if the tumor size reach to a 50% reduction, we consider that as a partial response. So in melanoma, actually we see most of the response rate, close to 30% of the patient will respond, which means if the patient responds, the chance for this patient to live longer is very high. In some cases, when we discover after 10 years, or I think so far data have 8 years after treatment, they live with tumor-free conditions. But in lung, it's more difficult, and here I'm talking about the renal cell carcinoma, which is also difficult because the response is much less. And then for bladder, that's our drug we got approved this year in May, because we see 52% of objective response rate in metastatic bladder cancers, which is that's very, very exciting thing, because which means half of the patient would benefit from this drug. It never happened before in the era of chemotherapy or radiotherapy. So I just show examples. This data already been published. And this patient had a metastatic tumor here based on the CT scan. And then just after 2 cycles of treatment, you see that the tumor already disappeared, and after 8 cycles, and the tumor basically disappeared completely. Another way to looking at many patients, and here we're just looking at the change of the tumor volume from baseline. So when the line goes up, means the tumor is growing. When the line is going down, which means the tumor is being inhibited or eliminated. So this is, have all these cohorts would all benefit from the treatment. This is looking at about 250 days, almost a year of time. Yeah. So now this drug is being approved. And then I want to also bring your attention to the tumor type. I talked about the tumors. Every patient has different tumor type, have different immune system. This is a perfect example to show you. So this is in some cases, the patient, if you took a biopsy, when we look at the immune system, you will see they are infrared, which means there's immune cells infiltrated into the tumor. Here we're talking about the T cells. But then in some tumors, it's also interesting to look. There's a lot of T cells are there, but they are sitting on the line at the border of the tumor mass. But they don't have a chance to really get into the tumor to kill the tumor. And then in some cases, there's nothing there. There's black. There's only tumor cells, but there's no T cell. There's no other tumors immune cells. So for these different cancers, the strategy will be very much different. Also, we have already identified, for example, for most of melanoma and lung cancer, and the chance to find infrared tumor is much higher than those a patient with ovarian or gastric cancer. Basically, in this patient, there's no T cells involved. Then the treatment will be responded differently, and then also that will help us to develop different strategy against this different type of treatment. So I mentioned there's different ways of combinations. There are different ways of targeting tumor cells. So there are every steps, and you can use different strategy to even combine different strategy to maximize the benefit of having this drug to target cancer in this case. So just give you as an example where we have a combination of 2 different drugs. So one of the drug is called COBI, it's a targeted therapy, and then plus this is in combination with the drug I showed you. It's called T-Centric and for blood cancer, and then here it's called the science name is called atezolizumab. And then you can clearly see when you combine 2 drugs versus just one single drug, the response is different. Here, just looking at the T cell infiltration into the tumor, you see a massive infiltration of the tumor. In the end, basically, the tumor will fill up with powerful effect T cells after the combination therapy. And then another type of antibody, I already mentioned briefly. We have antibody to recognize the antigen antigens, the CEA. And then we have another recognition moiety bind to CD3, which could bring the T cells directly to the tumor site. Particularly for those patients who probably have no T cells involved, then you can really have the antibody attract your T cells from circulation, drag them into the tumor site, and then activate the tumor locally because of CD3 signaling, and then that could lead to the killing of the tumor. So also, I show you another examples where we even did a combination studies. And this is in animal models. This is our antibody I just mentioned, the CEA, CD3 bispecific antibody. So this is a control. In the control, the tumor will grow in mice. Then we have this particular antibody. You see, the tumor growth is inhibited. Also, prolonged. The survival time is prolonged. And then, if you have the combination of the 2, which is in orange color, you will see a benefit of synergized effect of inhibiting tumor growth here. And this combination is right now in the phase 2 clinical trials. So let's see how this drug is being developed. We do have very much confidence that this molecule is going to move into the market very soon. So there's many combinations when we talk about cancer immunotherapy. And I hope I can give you some examples how the cancer immunotherapy is being developed, and give you also a bit perspective of what the future will be. And we think this is called so-called checkpoint blockade will remain as the backbone of the therapy. And then the combination of the therapy with one of this checkpoint blockade will be the key for the future, and it will be a standard of care in the future. And how many combinations, we don't know. We are actively working on many combinations. What we believe in the future, it's going to never be a single therapy, a single molecule is going to be used as standard of care. It's going to be always a combination of 2, a combination of 3, even 4 or 5 different drugs, because we understand exactly how this individual drug is targeting different components of the immune system. So there's a lot of things. I'll just skip this because this is more talking about the precision cancer immunotherapy, which is a national program both in China and the US. And because we realize many cancer cells, they have a mutation, and then essentially with modern technology, we can sequence every individual patient to find what exactly are those patients. Then we can develop a therapy, especially to give a power to engineer the T cells from patient to recognize that specific mutation on the T cell or on cancer cells. So that's more for the future. I think I'll stop here. If there's still time, I'd like to take some questions.
Wonderful.
Thank you
I think you're very good method, very scientific. But I want to know, do you try any herb medicine or plant to do the work?
I wish I have freedom and found company, but right now the company is not even interested in herbal medicine simply because they don't understand. So we need some like a clinical evidence to show how our herbs are working. If say we have several herbs could enhance the immune system, what exactly they do? We need to use this animal models. Say, okay, by giving these herbs, and let's look after 2 weeks of the treatment, look into the tumor to see what are the immune cells being changed. Do we see infiltration of the activated T cells there? Do we see a shrinking of the tumor cells? How the tumor is being shrinking is because of the killing of the T cells, or because of the apoptosis being induced, or because of some opposite direction or overall modulation in the whole microenvironment of the tumor.
Anybody else?
Can I ask a question? You've given us the good news. Tell us about side effects, please.
Yes, that's a very good question. It's always, of course, so if the side effect is too strong, the FDA would never approve any drugs. So the safety margin is always very, very sensitive issue. And so far, all these drugs in the clinical trials, they are all being very safe. And often, I think the side effect so far we observed is mostly fatigue and some fevers. And this can be easily managed by corticosteroids. So there's no really a danger side effect has been observed. But if you're looking forward, if we bring 2 immunotherapy, if we bring 3 immunotherapy combinations, that will increase the risk of having an even bigger side effect. So that need to be closely monitored. Actually, that's the main challenge issue. We are actively working in the clinical settings to find out the safety margin for those different combinations.
Okay, it's okay.
Yes.
I asked you about the, you talk about immune drugs for cancer. I read, I saw the program about the patient become resistant for these drugs after a period of time. So what are you going to do with, is that quite common, happens?
Yes, this is still at a very early stage, and we do expect some of the patients will get resistance as those targeted medicine has happened to the patient. And I think right now we still don't understand how the resistance could happen by this different chemotherapy. Of course, I think that because the immune system is so complex, as you see, there's many cells that are involved. So I think it's still too early to say what would be the strategy, but definitely that's something it's in the scope of discovery.
Can I give you the last question? I'm loud enough on this.
Okay.
Do you know how many years they have been using chemotherapy before they now realize it's not working? By the same token, and do you know how many years before they are now using this new targeted therapy before they realize it's also not working?
When the chemotherapy came offline, I have to say that saved millions of patients, or prolonged their life. At least majority of the patients benefit from the therapy, but also they probably benefit from therapy to make them die in the end. That we don't know. Those drugs being approved because we see the benefit. If there's no benefit to patients, and those drugs will never be approved. I think that's the bottom line.
Well, I think it's arguable that they now recognize chemotherapy is doing more harm than good before they give it up and change the direction.
But the thing is, at the time, in early time, let's say in the 80s, when the chemotherapy became the main standard of care, we had basically had no other choice. We had no other options.
Yeah.
That's the best option at the time. That's why I call standard of care.
I agree they have no option, and I think they are still on the path of learning. They've not really found the right solution yet.
Okay, thank you for your question.
Can I just make a further comment?
I will present the sum because we have a session that will
Could
Barry,
comment there, just one comment. So the lady, the drug companies, pharmaceutical companies are into business planning. What is coming now, they knew about decades ago. In 1972, they said they would solve cancer in 10 years.
I heard that before.
It's marketing, it's business, it's profit.
Yes.
Patent it and you can make money. The statistics they produce, anybody here who's a statistician knows the statistics are flawed.
Yeah, we can
And that's the point I want to make in
talking
face of
after
what the
break.
lady's saying. Thank you.
But thank you. According to the lecture from Dr. Zhao and Dr. Ho, now we come to the same branch. According to his presentation, that he shows our three pictures. I found it's important. One cell is inflamed, another is immune excluded, another is immune desert. So now question, according to the theory, normally if cancer starts, we expect that T cells should come together to fight for our body. But in fact, they did not. So Dr. Zhao came to the conclusion that in the beginning we should not stimulate the immune system too much, right? And later stage, yes. But now how for us as practitioners to master the point when to invade, when to start this supporting? So do you have the idea? So his idea is general, in the beginning not. But it seems in the beginning that T cells also don't involve this, cancer cells. Is that the same with TCM theories? So how can we combine these theories? And I think my idea is, I agree, according to Dr. Zhao or Dr. Ho, that differentiation. I think it's important. I had talked with him during the lunch break. He shared, he's a scientist, he shares same idea as a TCM normal principles, that differentiation is very important. Could you please tell our audience again?
I think that's very good point to discuss. I think the immunohistochemistry thing, which I showed on this cancer biopsy, is just one part of the science we had. Because based on that, you can only recognize how the immune cells, how the tumor is composed by different subcells. And then we have other technology to dig into those patients, dig into those cells to see what kind of function do they have. So, for example, we see some T cells there. We can isolate. We could use some immune marks to check: are they really active? Do they have the right weapon already on their surface? If they're not, we're going to breed them. We're going to provide a kind of activating agent to activate them. But if they have kind of inhibitory molecules expressed too much on the surface, then we have to use the antibody, which could block that signal. So it's very much different at the cellular level, at each individual settings.
Therefore, there's a new term called precise medicine initiative. It's a new term, but I think it is a fresh new term for us. However, it is not for us, for TCM practitioners, because TCM we have a differentiation. This is what already we used for 2,000 years, right? And if you agree, so thank you very much.
Thank you ever so much for the Dr. Xu. He gave us a very good talking about the research to found the new medication. But now we have another approach about Mr. Henry McGrath. He shall be give our talking about the clinic practice of the natural therapy. Henry has been practiced